Today, we're taking a highly visual journey into the life of the reticulocyte. We're going to visually map out exactly how these vital cells are formed deep within the bone marrow, track their brilliant, colorful maturation over a couple of days in the blood, and follow them all the way to how we actually analyze them under the microscope and on automated analyzers. Here is our quick agenda for today. We'll kick things off with their introduction and clinical uses. Then we'll cover the specific stages of maturation, tackle staining and those tricky common mimickers, break down manual and automated counting methods and formulas, and finally, look at interpreting reticulocyte counts. Starting with Section 1, Introduction and Clinical Uses, focusing on the true clinical value of the reticulocyte. So, as we can see beautifully illustrated right here, reticulocytes are newly released and mature red blood cells. What makes them so special is that they still contain this delicate internal reticulum made of residual RNA. Now, your standard stains are just going to miss this entirely, which is exactly why we use Supravital stains. Look at how new methylene blue makes that reticulum absolutely pop as these vibrant blue filaments. Brilliant Crystal Blue gives us this really striking purple network, while Azure B yields a super crisp blue that, as we'll see later, is actually the preferred stain for automated counting. Basically, these Supravital stains only highlight the RNA, leaving the fully mature red blood cells essentially blank. The clinical utility we get from this is just vast. By quantifying these really colorful RNA networks, we're essentially looking at a real-time mirror of recent red blood cell production. We use these counts to assess baseline bone marrow activity and to see exactly how well a patient is responding to therapies like iron, vitamin B12, or EPO. And crucially, this is what allows us to instantly differentiate between anemias caused by decreased marrow production versus those caused by increased destruction or blood loss out in the periphery. It's literally a direct window into the marrow's capacity to respond to stress. Moving on to Section 2, the stages of maturation, looking at that critical 1 to 2 day evolution. Let's look at this progression. Over the course of just a 1 to 2 day incubation period in the blood, this cell undergoes some really profound physical changes. At stage 1, right out of the gate, you see a really dense, cohesive reticulum, just a heavy bundle of RNA. Give it about 12 hours to reach stage 2, and it starts unraveling into a loose, extensive network. Fast forward to 24 hours at stage 3, and it's reduced down to a small reticulum with just a few scattered granules. Finally, by 48 hours in stage 4, you're left with just isolated, scattered granules. Visually, you can see everything is steadily decreasing here. The RNA content, the physical structure, the stain intensity, and even the overall cell size literally shrinks as it matures. But hey, before we actually begin counting these stages, we really need to define what not to count. We have stage 0, which is the late orthochromatic normoblast. Now, this is a nucleated red blood cell that also exhibits extremely strong reticular staining. But because it still has its nucleus, it is strictly excluded from our final reticulocyte tally. We are only interested in the non-nucleated stages for sure. So what do we actually find when we look at a healthy patient's blood smear? Well, you're really not going to see many of those dense stage 1 cells. In fact, stage 1 and stage 2 combined make up less than 1% of normal circulating reticulocytes. The vast majority of what we encounter clinically are the highly mature variants. We're talking stage 3 at roughly 32% and stage 4 at a massive 61%. So combined, these late stages make up 93% of the normal distribution you'll see under the microscope. All right, let's jump to Section 3. Staining and common mimickers are what I like to call the art of detection. Okay, so the microscopic world is absolutely full of inclusions that can easily masquerade as a true RNA reticulum, and these visual imposters routinely challenge us. We've got Heinz bodies, which are a precipitated denatured hemoglobin seen in things like G6PD deficiency. They look like these round, refractile bodies. Then there are Pappenheimer bodies, those coarse iron granules we see in sideroblastic anemia. We also have to watch out for hemoglobin H inclusions in alpha thalassemia, and Howell-Jolly bodies, which are those perfectly round, basophilic DNA remnants you often spot after a patient has had a splenectomy. To avoid misinterpretation here, and to make sure we aren't artificially inflating our reticulocyte count, we really have to correlate the morphology with specific stains. For instance, true reticulocytes will enthusiastically stain blue for RNA with Azure B or new methylene blue. But if you're looking at a slide and suspect those coarse dots are actually Pappenheimer bodies, you absolutely must use a Prussian blue stain to confidently identify that iron content. It's all about matching your visual cues to the actual biochemical reality on the slide. This brings us to Section 4, Counting Methods and Formulas, covering both manual and automated quantification. Let's dive into the actual math of hematology. For manual counting, the Miller ocular disc method is just a beautifully elegant optical procedure. You insert this disc right into the microscope eyepiece, and it gives you two squares. You count your stained reticulocytes in the large square A, and you count your mature red blood cells in the smaller square B, nestled down in the corner. You repeat this across 20 different fields. The geometric genius here is that square A is exactly 9 times larger than square B. This lets us sample a solid number of rare reticulocytes against an overwhelmingly huge population of mature red cells without literally losing our minds trying to count thousands of individual mature cells by hand. Once we have those raw manual numbers, we apply some foundational formulas for the patient record. First, the standard reticulocyte percentage gives us a ratio normally sitting between 0.5 and 2.5%. Next, we have the absolute reticulocyte count, or ARC, which multiplies that percentage by the total red cell count. This gives us the actual number of reticulocytes per cubic millimeter, which is normally around 50,000 to 85,000. And finally, we have the corrected reticulocyte count. This one is super important because it smartly adjusts the percentage based on the severity of the patient's anemia by factoring in their specific hematocrit against a normal hematocrit of 45.
Now, while the Miller disc is a total classic, modern automated reticulocyte counters represent a massive leap forward. By utilizing specific stains like Azure B in combination with flow cytometry, these analyzers dramatically improve our accuracy. They effectively screen out all those visual mimickers we talked about earlier, like the Heinz bodies and Howell-Jolly bodies. This significantly reduces the false positive results that can kind of plague manual counting methods, giving us incredibly reliable data instantly.
Let's wrap things up with Section 5, interpreting reticulocyte counts and their clinical significance. Zooming out from the microscope to the actual patient, these final numbers tell a very distinct story. An increased reticulocyte count shows us a robust, adequate bone marrow response. The marrow was working overtime to push out those stage 1 and 2 reticulocytes because of stressors like hemolytic anemia, acute blood loss, recovery from nutritional therapies, or even physiologic stress like high altitude. On the flip side, a decreased count flags impaired or ineffective erythropoiesis. Even if the patient is severely anemic, the marrow just isn't responding. That points us straight toward conditions like aplastic anemia, chronic kidney disease where that vital EPO is lacking, nutritional deficiencies of iron or B12, or even dangerous bone marrow infiltration. From the dense RNA networks of a newly born stage I cell to the precise calculation of an absolute automated count, these transitional cells are truly indispensable messengers. So, as you go to interpret your very next CBC, I want to leave you with this thought. How does meticulously correlating these vibrant, real-life cellular morphologic findings with your automated diagnostic data fundamentally transform your overall approach to untangling complex anemias? Keep an eye out for those beautiful blue filaments out there, and we'll see you next time.